Good morning, and welcome back to Global Neurosciences Institute Grand Rounds. And now it is my great pleasure to introduce our speaker, our own Dr. Adam Sarkar. Dr. Sarkar became a national recognized Westinghouse Science Scholar prior to attending Brown University as an undergraduate. During this time, he investigated issues related to viral oncology at various institutions, including the Ludwig Institute of Cancer Research in Switzerland, the Rockefeller University in New York, and the University of Georgia in Athens, Georgia. Dr. Sarkar received his MD PhD degrees from the University of Miami School of Medicine. His PhD dissertation was conducted in the Department of Physiology and Biophysics with a focus on molecular neuroscience. This work culminated in cloning and characterizing neuropeptide receptors from the brain and earned research distinction from the graduate school. It was at Miami that an interest in neurosurgery was galvanized. A fellowship at Columbia University in single molecule mechanics, nanotechnology, and instrument design were the focus of his postdoctoral work. The postdoctoral fellowship was performed in the midst of neurosurgical residence at the Mayo Clinic in Rochester. Dr. Sarkar joined a Global Neuroscience Institute in 2019 as a neurosurgeon and is a professor in the Department of Neurosurgery at Drexel University College of Medicine. Dr. Sarkar serves as a director of neuro-oncology, as well as director of the Adult and Pediatric Stereotactic, Functional, and Epilepsy Surgery Program for GNI. Dr. Sarkar will be speaking today about Parkinson's disease.
Perfect. Well, Peter, thank you so much. Thanks for the introduction and thanks for the opportunity. Listening to everything you said made me feel tired for all the things that I seemingly have done in the past. Indeed, I am here, a part of the group of Global Neuroscience at Drexel, and I'm really excited to talk. I always am excited to talk about Parkinson's disease because I think it's something as a part of what we call functional neurosurgery that we make just about the greatest, deepest impact that I can imagine for our patients. There are some tulips in the background behind this, and that's not because I'm a horticulturalist or anything like that. It has to do with the fact that a Dutch horticulturalist was developing a tulip, and this is called the James Parkinson's tulip with red and this white flare, and he had Parkinson's disease, and he developed this breed specifically with that in mind. Let's see, let me advance. Now, you mentioned a lot of places that I've been. This is just a pictorial depiction. If any of you have any of these logos on sweaters or T-shirts in your closets, come find me and we can commiserate or reminisce. I think this set of images, I like to start my talks off with sort of a little bit of history. A lot of this will be history, but for as long as humans have gathered as communities, and that's about 10,000 years in a period which is called the Neolithic period, there's been a fascination with the skull and the brain, and as such, really the rudiments of neurosurgery and neurology were formed. There are 4 images here. This one down here, which is a hieroglyphic, is the first time that the written notion of brain was depicted. This picture over here of this skull, which actually underwent what we could call a surgical procedure, is from Western Europe. This skull that underwent another surgical procedure is from South America, and then this is from North America. I don't know that it's a surgical procedure. I think that was post-mortem, but you can see that there was this fascination with the brain and the skull. And why these procedures were being performed, they can only be speculated. Probably it's mystic, spiritual, or some kind of ritual. But nevertheless, these ancient shamans and healers do have a weak thread towards us and our understanding of what we do as neurosurgeons today. Now, neurosurgical interventions can be considered as corrections of structural, say, problems. For instance, over here, this guy had the most interesting story. It's a CAT scan There's an arrow pointing to this hyper intense area, which is called a colloid cyst. He would get headaches and then periodically would just shake his head violently, and then his headaches would disappear. And he learned how to do that on his own. We all surmised that he probably had a colloid cyst. Well, he has a colloid cyst. It was probably obstructing his outflow of CSF. Once it obstructed it enough, if he would shake the colloid cyst enough, then CSF could pass. But we didn't want him to go through his life like that. And we did this surgery, took out the colloid cyst, and it almost looks like we weren't ever there. So again, taking care of structural problems, that's what we're frequently known as neurosurgeons. Sometimes the problems can be as small as this colloid cyst, just under a centimeter. Other times they can be quite large tumors like this sphenoid wing meningioma, which is several centimeters. And then many of you know, as neurosurgeons, we take care of spine problems. So again, taking care of structural problems is what I think most people think of as neurosurgeons, fixing things that rupture, fixing things that are broken or out of place within the axis of the CNS. And even tumors can be considered structural problems. And in this picture, these are MRI scans. The red is false coloring of a tumor. This is a temporal parietal occipital mass. It's involving the posterior aspect of the, it's impinging on the posterior aspect of the left ventricle. And the patient didn't even appreciate that they had a visual defect until we demonstrated that to them. This person was actually a truck driver, and it was the loss of the ability to read that prompted their admission. They couldn't read the exit that they were getting off at. They could spell and recite letters, they could read numbers, but the ability to process letters into words was affected. So we did a surgery, a structural surgery, took out the lesion, and a couple of weeks later, they're already starting to recognize simple 3- and 4-word letter words and being able to read them. So that's typically often what we do as neurosurgeons, and it is absolutely rewarding. But in contrast to such structural problems that I've briefly alluded to, movement disorders, which is what we're here to talk about today, and the patients with movement disorders are distinctly different. And an individual that has, say, an essential tremor, Parkinson's disease, or dystonia, there's not really a true structural defect in the sense that there's something pushing on something. And yes, we'll get into it, there is a loss, but it's not that kind of tumor that's growing or broken spine or colloid cyst. But even though these aren't structural problems, neurosurgeons have been actively seeking intervention for patients with these diagnoses since the foundation of our specialty. And as a matter of fact, treatments for Parkinson's, surgical Parkinson's disease, have been a keen interest for over the last 130 years. Now, this is a montage or maybe even an homage to James Parkinson's. In April, and that's why I really wanted Peter to allow me to give this talk in April. April is Parkinson's Disease Awareness Month. And it's been just over 200 years since James Parkinson published his manuscript in 1817. You'll see it down here, which is incredible. It really is. This monograph, an essay on the shaking palsy, is what really cemented him into our vernacular. Those people that are kind of devotees of Mr. Parkinson will appreciate that he only reviewed or evaluated 6 patients, and 3 of these patients were even evaluated from just casual observation, or as Parkinson put it in his own words, next noticed was casually met in the street. So these were just his observations from folks, not necessarily putting them through stringent physical exams. And Parkinson's keen sense of observation allowed him to identify some of the real cardinal features of what was then designated the shaking palsy or paralysis agitans. There's a tremor, rigidity, and the postural instability. Those are the things that he was able to see. But it really wasn't until later that the great French neurologist Jean-Martin Charcot, he made a real meticulous analysis and added the fourth cardinal feature of Parkinson's, which is bradykinesia. And it was also Charcot who suggested that such individuals should be designated as Parkinson's disease patients. I want to spend another moment on James Parkinson. Mr. Parkinson was a man of many talents. They were both medical and non-medical. And like his father, he was also a pharmacist, apothecary. He also had non-medical interests that included geology, paleontology, and he was a very staunch political activist. But I think, and for me, always makes me smile, what's perhaps forgotten with the passage of time is that Mr. Parkinson was a surgeon. And you can see that. I've kind of put my pointer here. And it's his affiliation as a member of the Royal College of Surgeons is prominently evident on his landmark publication. But certainly, by no means would I mean to imply that Parkinson was a neurosurgeon. Historic trephination, which we saw in some of the earlier pictures, notwithstanding, neurosurgery as an emerging field wouldn't occur for nearly 70 years when the neurologist William Gowers and the pioneering neurosurgeon Victor Horsley collaborated. So as such, even though Parkinson described this, and even though he was a surgeon, he could really only employ contemporary therapeutics. And Parkinson's advocacy for solutions here were in keeping with the time, and that was bloodletting and blistering. And while methods seem antiquated, he still, however, had a belief that these maneuvers were relieving inflammation in the area of the medulla. And while that's certainly not correct, it's at least prescient in suggesting a subcortical extrapyramidal pathology. Just to summarize, there are about 10 million individuals globally carrying the diagnosis of Parkinson's disease. And Parkinson's disease is a neurodegenerative disease, which is only secondary to Alzheimer's disease with regards to neurodegenerative prevalence. Many of us learn in medical school that these dopaminergic neurons, these brown neurons here, are lost in the patients of Parkinson's. The reason for and the mechanism for their deterioration is not entirely clear. Aside from the fact that we know that we find some dysfunctions in certain proteins. One protein is called alpha-synuclein, but 90% of Parkinson's disease is what we call idiopathic. So while their causes of Parkinson's disease are unknown, there are risk factors. Age, for instance, Parkinson's disease can affect anyone, but it's infrequent in young adults. And it increases in frequency 5-fold in individuals over the age of 85. There is a small hereditary component. It's murky, however, at best, but it cannot be ignored. But what is apparent is that having a close relative with Parkinson's disease increases the chances of developing the disease itself. And then there's a male-female skew. Men are about 1.5 more times more likely to develop Parkinson's disease than women. And then finally, there are some environmental etiologies. I wouldn't say that they're absolutely strong like the way asbestos is with lung disease, but certain herbicides and pesticides may slightly increase the risk of Parkinson's disease. Now, in addition to the individual loss of autonomy, as the disease progresses, an estimation of the national cost in the United States is over $50 billion to the healthcare system. So it is really a major impact on healthfulness and care in the United States and worldwide. Now, I want to get back to the notion of surgery and movement disorder. And it's incredible to think in this sort of depiction over here. This on the left-hand side is a surgical operating theater in the early 20th century, so 1930s or so forth. And I can't even begin to imagine how they did the surgeries that they did. Movement disorders in general fascinated neurosurgeons from the start. And it's perhaps because the manifestation of the debilitation was so obvious. For instance, if you had diabetes and your A1C was out the roof, 200 years ago, nobody knew that anything was going on. But in a condition such as hemibolism, Huntington's chorea, or Parkinson's disease, well, these offered an opportunity to seek a surgical therapeutic amelioration by disrupting motor pathways. And all points of contact from the motor cortex through the internal capsule down through the brainstem into the spinal cord were even experimented on to see if there was any way of helping patients that were afflicted in such a manner. And as early as 1890, Victor Horsley resected the motor cortex, and that's up here. And while his operation gained what we'll call popularity in quotes, over the ensuing 20 years, it became very clear that such an approach was risky, ineffective, and frequently left the patients far worse off. For instance, in Parkinson's patients, while the immediate postoperative period saw disappearance of the tremor due to the motor paresis, the tremor would relapse with the extrapyramidal rigidity being substituted for pyramidal spasticity. So even more disappointing was the progression of the disease. And Parkinson's disease patients, having undergone such cortical resections, were left with a paretic limb that was in the contralateral side to the surgery, and a tremor now that was marching on in the other limb as the neurodegenerative disease progressed. If you look further down in the brain, so initially it was thought, okay, let's stay away from the cortex. Maybe subcortical surgery might help. And so that, if you know some degree of anatomy, would be, say, the internal capsule. Well, how do you get to the internal capsule? Right now, we can identify it on an MRI scan. We can use neuronavigation, but this is over 100 years ago. How would they find the internal capsule? Well, they'd actually use the ventricle. The fluid-filled system in the brain, the ventricular system, was an avenue that they, early surgeons would use to find the caudate nucleus and then work their way back in through the anterior limb of the internal capsule to the fibers at what's called the genu to create a subcortical paresis. This is absolutely crazy. Well, the technical skill here must have been insane, but not surprising. These outcomes were no better than those of the cortical resections, with the added downside that now you had what's called intraventricular entry or surgery, and it increased the risk of complications. And additionally, there were behavioral changes from the destruction of the internal capsule anterior limb, and these left patients neuropsychiatrically altered. That's a very kind way of putting that they were very badly hurt. Continuing with the quest for a subcortical pyramidal tract that would be suitable for destruction was a proposed sectioning of how the pyramidal or the motor system gets its name, and that's from the medullary peduncles. The peduncles in the medulla, well, actually the peduncles in the medulla are down here. The medullary peduncles, which carry the cortical spinal fibers. And there was a way of doing a surgery that was not through the ventricle that was called subtemporal, therefore avoiding the complications that were associated with the intraventricular surgery. But even though this was an incredible feat, unsurprisingly, this surgery, which was called a pedunculotomy, which had its own proponents, compromising the pyramidal tracts here, whether you did it above at the cortex, subcortically, or here at the brainstem, it still left an indelible, typically unsatisfactory impacted patient. And then going down the road to the spinal cord, surgical approaches were employed, but fundamentally these efforts, coupled with low success, high complication rates, are effectively remnants of the past. So people were trying. And I made the distinction where I said pyramidal and extrapyramidal. And I don't know if that was really well received or kind of fixed on, but our motor system, say, if I wanted to move my hand, that's the pyramidal system, the corticospinal, and you can also include corticobulbar tracts. There's another system in play that's evolutionarily older, that's not at the cortex. It's in the midbrain and the brainstem and in the deep nuclear structures, and that's called the extrapyramidal system. So everything that goes through what's called the medullary pyramids is a pyramidal system, and everything that goes elsewhere, meaning through what's called the tegmentum, is the extrapyramidal system. An easy way to remember this is if you think of a young Michael Jordan trying to get onto his high school basketball team, which he was never able to get onto, while he's practicing his free throws and his corner jump shots, he's employing the cortical spinal system of the pyramidal tract. But by the time he makes it to the University of North Carolina, where he can make those shots with his eyes closed, he's using the extrapyramidal system as his memory system for his motor actions. So the two systems are very intertwined and interrelated, but it was a while before we actually understood that Parkinson's disease was a problem of the extrapyramidal system. So here's a really nice example just to show you that here's the motor cortex up here. Neurons coalesce, come through the cerebral peduncle, and then at the level of the medulla, they enter what's called the pyramids, and that's why it's called the pyramidal tract. The next picture is not to scare anybody, but my goodness, when I was learning the extrapyramidal system, you get these beautiful colored pictures, but they were frightening with the sort of like the interconnectivity. But this is not only frightening, but an opportunity to afford fine level of control. And I think either you're kind of absolutely engaged by looking at this map of the basal ganglia and the extrapyramidal system, or it probably relegates you to dermatology or something like that, where you have nothing to do with neuroscience. Now, if we go back in this discussion, the notion of surgery on the basal ganglia and the extrapyramidal motor system, I haven't even discussed. And that's because one of the founding fathers of American neurosurgery, the preeminent surgeon Walter Dandy, felt that the ventral striatum, which is part of the basal ganglia, was critical for consciousness. And as such, the impact of his conviction dissuaded neurosurgeons for years to do any kind of pursuit on basal ganglia structures. And it really wasn't until a matter of serendipity for neuroscience and neurosurgery, but not for the patient. And it involves these two guys, Russell Myers and Jefferson Browder. And they're in New York City. Russell Myers was attending at the King's Hospital when he was on call and received in 1939 a woman who walked into a propeller at a local airfield. And the propeller had shattered her skull, opened her up bifrontally, and created ventricular injuries such that he could look at the damaged striatum. And she was still awake, and she was still conscious. And it was that sort of quote unquote serendipity that allowed Myers and also Jefferson Browder, who was his colleague, to believe that they might improve in functional outcomes for patients with Parkinson's by operating what we'll call safely, but in heavy quotes, and selectively on the extrapyramidal system without compromising consciousness. And while much can be lauded for this bold innovation, there was high morbidity and mortality in working on the basal ganglia, at least at that point in time, and it rapidly fell out of favor. I love this one quote here. Russell Myers was actually famous. He was a surgeon, but he was also a keen neurologist. He was on Foster Kennedy's service at Bellevue Hospital. He started his postgraduate training as a surgical intern at the Brooklyn Hospital. But if you look into his history, it says that he was dismissed after a few months for amusing reasons, but all of them professional. I have no idea what that means. Jefferson Browder was impressed by Meyer, having met him before, and offered him the first neurosurgical residency position at King's Hospital in the Bronx, or in Brooklyn. In 1952, it was a serendipity that brought Irving Cooper into the mix. What happened was that this was a notion where people were doing pedunculotomies, and pedunculotomies were being performed on a lot of patients who had post-encephalitic Parkinson's. So this is from the influenza of 1918. It left people with a Parkinsonian type syndrome, and there was this notion of resecting the descending corticospinal tracts at the level of the peduncle, which is in the midbrain, and trying to afford relief. Well, Cooper was performing an operation on a patient, and he encountered ferocious bleeding that forced him to ligate what was later to be determined the anterior choroidal artery. That's this artery over here. What must have undoubtedly felt like an intraoperative calamity turned out to be a surprising postoperative success, as the tremor in that patient and the rigidity were quelled without any kind of hemiparesis. And like other innovative operations in the history of functional surgery, however, early enthusiasm was quashed by complications that really included unacceptable high morbidity and high mortality. So now, that all seems interesting, exciting, and maybe a little bit depressing, but it was really clear from Myers and Cooper's independent observations that whether resections or vascular occlusions, respectively, were performed, that the future of Parkinson's surgery lay in some kind of innovative selective ablation of the basal ganglia. And if that could be done, there would be minimal morbidity. So another point worth emphasizing is that movement disorders such as any of our surgical investigations, starting with Victor Horsley and modified by global pioneers, were only able to address 1/2 of the symptoms, or hemiparkinsonism. In other words, in a disorder which manifests bilaterally and is a progressive disease, this was another limitation. So, okay, let's say you resected the motor cortex on one side, but you were only helping one side of the body in a disease that's bilateral. So I think it's, despite the limitations in definitive surgical therapies emerging in the periods from 1890 to 1960, those surgeons and their teams really have to be applauded. It's easy to forget what little resources were available to them at the time. And there's certainly little in the way of any type of modern imaging or intraoperative navigation that were available to them. And for sure, visualization of the operative field or even magnification or illumination were really limited. And so in that context, the notion of these collective investigations really have to be taken with a grain of remarkable innovation. Now, it would be logical to transition to a discussion of stereotactic and modern functional neuromodulation and neurosurgical procedures. But I think any discussion of Parkinson's disease really needs to highlight, at least briefly, the notion of the problem, and that was dopamine. Dopamine is fancifully arrayed here with the hydroxyl groups as being this flower and the amine group over here being this double flower. Arvid Carlsson received the Nobel Prize, I think that was in 2000, for his work on dopamine and Parkinson's hypothesis. But really, I'd like to bring your attention to somebody that I don't think is necessarily as well known. And this is Ole Hornykiewicz. And he is really fundamentally important to any discussion of Parkinson's disease. And back in July of 1961, in collaboration with the neurologist Walter Birkmeyer, who was at that point in time the head of the neurology wards in Vienna's largest home for the aged. These two effectively, and it was really Hornikiewicz, established the medical and pharmacological practice of transmitter-based therapeutics, which are today widely used. And the dopamine miracle is what happened when they infused L-DOPA into a patient with Parkinson's disease. And in Hornikiewicz's own recollections of the results, these results were spectacular. And so, not surprisingly, with this, interest in surgery waned. Some of you may not know of Hornikiewicz, but what you might recall is this either book or movie by Oliver Sacks called Awakening, and it had to do with encephalitis lethargica. This was a problem again from the last influenza of 1918, and it was Oliver Sacks's description of how he used L-DOPA in these patients. Many people might think that that was the first inception of the use of L-DOPA, but the L-DOPA miracle actually happened in Vienna. So just to put some context into something that you might know of just through pop culture. Now, I want to move on to something called stereotaxy, and that's what I do. And stereotaxy is when you put something within a framework, whether it's a grid or a map, and that you can relate other structures to it. And in India, for instance, at this site in Jaipur called Jantar Mantar, the stereotaxy of these devices on these grounds are used to use the stars as fixed reference points for telling the time. And these devices, even though they were made in the 18th century, are accurate up to 2 seconds for telling time. I don't use anything like that, but I do use things that have evolved. Victor Horsley used this device on animals, where he would use the external references of the skull to try to make selective, repeated, reliable lesions in animals. But it really wasn't until ventriculography and two guys in Philadelphia decided to innovate. That's Spiegel and Weisses. So Philadelphia, we all live here, is the birthplace for many American institutions and ideas and inventions, and human stereotactic surgery found its inception here too. The neurosurgical collaboration between Ernest Spiegel and Henry Weisses at Temple University really heralded the first human stereotactic procedure, and this is in 1947. Their device was called the stereoencephalon, and their first patient was suffering from Huntington's chorea. And the genius of this approach was that for the first time, internal landmarks, such as the outline of the ventricular system, and you'll be able to see that here, using the ventricular system to be outlined, or even the pineal gland, could be correlated to a brain atlas, which at the time the Temple team developed and used to approach safely, and again, that's probably in quotes, targets that were inside the brain. Again, this is just really revolutionary. I can't imagine how surgeons were doing these kind of procedures using these shadowy images, whereas now we have these MRI scans and understand that the anatomy of the basal ganglia is so complex to produce lesions. But stereotactic surgery for the next 40 years, from 47 till 87, would refine itself utilizing two principles: progressive minimalism and high fidelity targeting. And this was all really the state of play by making all these wonderful kind of, although they look like torture devices, ways of putting the brain into a 3D coordinate axis system and being able to, with high resolution, identify targets. But again, many of these targets were global targets in the sense that they were coming from a neurosurgical atlas of aggregate patients, but not unique to any one particular patient, which was a little bit of a challenge. I happen to use a different system, which relies on what we'll call GPS. I literally put screws in the skull so they're rigid, and I can use the screws that are in the skull to create a customized frame that allows me to target areas of the brain that I'm looking to either ablate or stimulate or biopsy. And this is in a way more kinder to the patient, because patients can move their heads. They find it much more, let's put it this way, going to have a DBS procedure is not a day at the spa, but they find it that much easier to tolerate. And we know that. In the early mid-80s, 1980s that is, everything changed. And that's because of this picture that I'm showing you here. The age of functional neurorestorative surgery really came to age. Neurosurgeon and also a physicist, Alim Benabid, was performing a stereotactic operation for movement disorders at the University Fourier, Joseph Fourier in Grenoble, France. At that point in time, surgeons were making unilateral lesions in an area of the thalamus called the VIM. That's this red area here. And what they would do would be stimulate with a low amount of current to make sure that they weren't here, too lateral in the internal capsule, or too posterior in an area called the somatosensory thalamus. Now, prior to creating their thermal lesion, like I said, they would use some stimulation to try to understand where they were, basically map the area, and then safely they would be able to ablate. But Benabid, for whatever reason, said, what would happen if I started at a frequency of 1 hertz and went up to a frequency of 100 hertz? And when he did that, he found that at 100 hertz, he stopped the tremor. And so I have to imagine that, much like the eureka movement that defined the the dopamine miracle, Benabid must have realized that high frequency stimulation rather than ablation might be a solution. And that really ushered in our modern era of neurorestorative, neuromodulatory, non-ablative surgery. And the beauty here is that we use the currency of the brain. We use electricity to elegantly offer a solution for a problem that has to do with dysfunctioning in electricity, to the point where some people call these kind of therapies electroceuticals. I want to not spend too much time, because we are running out of time. I want to spend a little bit of time on this video. Hopefully you can hear it. Preoperative area in our I've shown this before, if anyone's seen my presentations. And I think this is really the magic of deep brain stimulation. What we're going to do, you have a patient who's awake, they're in the operating room. The full force of neurosurgery is here, because it really takes a true village to help this patient. All right, we're going to get started now, Dale. We have electrophysiology, we have neuronavigation. We have an awake patient who can barely function here. And then when we've got an electrode in his brain and we stimulate him with electricity. Okay, we're going to go on now. 100 milliamp, ready and on. Okay, wow, still sweet. That's sweet. It really is magic for me. And it takes patients where signatures like this to a signature like this in less than 30 seconds. I'm not going to spend too much about how we target the subthalamic nucleus or the globus pallidus, and I'm not going to highlight the fact that these are really small targets. This is 6 millimeters. So to get here really takes a lot of planning and a lot of checking twice and cutting only once. We use, in modern times, still this anterior commissure, posterior commissure line, which is a vestige from when we used to do what's called ventriculograms. But we have really fancy imaging and software apparatuses to get us with sub-millimeter accuracy to where we want to go. And then we can really assure our patients excellent outcomes because we've taken together multiple modalities of neuroscience and bioengineering to help them get good outcomes. And I can't show this because unfortunately, I think the sound's not working, but these microelectrodes are used to record the various parts of the brain, like the subthalamic nucleus over here. And the brain, like different parts of the world, have different languages. So the neurons, say up here, will have a different firing rate from the neurons here and from the neurons here. And when we know that we're in the right spot, that's when we know that we can get an excellent outcome. Unfortunately, none of these sound files are working for me, so I can't share that with you. But I do want to show you basically what things would look like in the end. Here's a cartoon that shows electrodes in somebody's brain. They tunnel down to a battery. The electrodes are here on this CAT scan. It barely looks like we were there aside from this air. You can see this view from the side of the skull. The two electrodes are here. And where we put the pulse generator, I promise, even if you have a tattoo there, we'll make your tattoo look reasonable. I think the impact of the work of Alim Benabid, his insightful serendipity for Parkinson's and movement disorder was phenomenal because now it took the opportunity to take something that used to be only a poor solution for a unilateral solution to a bilateral problem to one that could now treat the whole body. And that I think is really, really fascinating and really, really wonderful. I think as we sort of wind down with time, the most important factor in predicting success for Parkinson's patients in surgery lies in the importance of assembling a multidisciplinary team. And we're very fortunate at GNI to have that. So ever since Victor Horsley and William Gowers, neurosurgeon and neurologist, collaborated, I think that collaboration of inextricable linked allow us as neurosurgeons with our neurology colleagues, neuropsychiatry colleagues to create innovation. The key is proper targeting, of course, but it takes a whole group of folks a whole lot of time to come up with these wonderful surgical solutions. It's been 50 years since the dopamine miracle, and it would be reasonable to muse at this point in time what the next 50 years will bring. And for neurosurgeons and neurologists alike, I think it's best to reflect back not on the success, but some of the major shortcomings regarding our current treatment for Parkinson's disease. Of the four cardinal features defining Parkinson's, the postural instability is the least likely to improve. In addition, there are several non-motor manifestations such as depression and dementia and psychosis, dysautonomia that can't even reliably be said to find any kind of relief from DBS or even from medication. And so what it really illustrates is that Parkinson's disease is a focal problem in the substantia nigra with a globally distributive effect throughout the entire central nervous system. For surgeons, this really means that the next challenge is to identify brain targets and networks that might be intervened upon in order to capture and improve greater number of Parkinson's symptoms. Now, the obvious being obvious, alterations to what innovation for the future will include alterations to the DBS hardware. Electrodes will become more sophisticated. Pulse generators will become more sophisticated. Therapy will be applied, maybe depending upon biosignals, such as local field potentials that will modulate the disease. And there may even be the notion of neuroprotection. But I think facetiously, and not so much so, if you look at this slide, it says that in the last about 25 years, there have been 200,000 patients that have been implanted with DBS worldwide. If you were to compare that to hip and knee operations in the United States, last year alone, there were 1 million procedures. So there's a real sort of discordance. And I think that that gapping disparity represents the prevalence of sort of an apprehension on the part of patients and caregivers for submitting themselves to surgery. And I think that not to be critical, and it's absolutely important to understand that movies and books from Ken Casey, The One Flew Over the Cuckoo's Nest, necessarily leave the public thinking that, my gosh, are you kidding me? I'm not going to have brain surgery for this. When in fact, I really believe that brain surgery for something like Parkinson's disease in the right patient, with the right setting, with the right evaluation, can be magic. I think that our approach to 21st century neurorestorative surgery really still has to use and employ strict ethical guidelines, constantly pushing technological innovation and progressive minimalism. And I think if we do that, we will always gain the support and the trust of our patients. And with that, Peter, I will stop and take any questions.
Thank you very much. Great talk, actually. Whereas people were texting me that it's such a, such a complex topic presented in such a clear way. We do have several questions for you.
Sure.
What is the success rate of going off medications in case, the surgery, when somebody goes through the surgery for Parkinson's disease versus essential tremor?
Yeah, so I mean, I think that that's a very reasonable question to ask. We never tell patients that by doing the surgery, they're going to be medication free. I think medication is the mainstay, and surgery plus medication is a way of improving just activities of daily living, maximizing patients, just coping with their disease. It's yet another way of doing that. If a patient comes to us with the expectation that they'll be drug-free, that's usually not a possibility. Sometimes it happens, but we don't say that up front.
Another question. So what is the perfect candidate for surgery? Somebody who has diagnosed?
Yeah, it's very interesting, Peter. It's one of those things where 25 years ago, when I first started residency, surgery was almost the notion of last resort. But now I think we're finding that why would you not do a surgery sooner in an ideal patient? Somebody, for instance, with Parkinson's that is definitely Parkinson's, where they're not having the other non-motor effects like the dementia or the dysautonomia, patient that responds to medication. Those patients, I think, we are seeing sooner and sooner, and I think we're making a greater and greater impact because we're really delivering them their livelihoods again.
Do patients who have non-MRI compatible devices, other devices implanted, are they candidates for these surgeries?
They can be, because at least in our GNI practice, and it's been my practice as I've always done this, I always listen to the brain with electrodes. Some people just simply do what's called direct targeting. They look for what's called the subthalamic nucleus, and they directly target that nucleus. We always listen, so we know where we are, and then we always stimulate, so we can deal with that. It's a little bit of a detriment, but we can deal with it.
Now, what are the complications of DBS and two groups of complications? One thing, direct surgical complication, and another thing is from the stimulation itself.
Yeah, so the
or unwanted effect.
Yeah, so the complication from surgery, DBS surgery, the biggest complication is over time, and that's infection, but that's a complication of any type of surgery. There can be a complication for when you're dealing with the brain and creating, say, like a hematoma or bleeding, but that's why we take a lot of time to look at our trajectory and make sure that our paths are the safest, most efficient, effective, shortest paths to getting to the target. So I don't think that surgery per se on the table has a complication. Complications can happen from the stimulation, but that's why we stimulate in the operating room. And I didn't make this point clear, but really what we're doing in the operating room when we're stimulating is we're looking for side effects. If you were to just place these electrodes, and it's called just direct targeting, it's a faster surgery, the patients are asleep, you just directly target to what you believe is the right site. Well, you might be in the wrong site, and then there are profound problems that you can't deal with. If we, for whatever reason, end up a little bit, a millimeter here or a millimeter there off, we can always change in the operating room. So we don't implant unless we know that we're going to get a good outcome. And then that allows our programmers like Dr. Farmer or some of our other colleagues to have the best opportunity to maximize a patient's success following our implant.
A question about psychosurgery. The OCD, in case of OCD, what are the targets? What are the patients who are, who could benefit from that? And any other psychiatric conditions that actually could benefit from the functional surgery?
Well, there are. This list here is from the FDA, and I'm really proud that we've done here at GNI every surgery from essential tremor to Parkinson's to dystonia to OCD and epilepsy while we've been here. So we've done everything that is allowable by the FDA. In other, under certain conditions like grants or research trials, you can think about depression. You can think about even things like headache. You can think about things like minimal conscious states, suicidality. In China, for instance, DBS is used a lot for neuropsychiatric interventions. It just hasn't really, I think, taken a lot of hold here. And I think in part that's because the public's sort of apprehension about, well, I don't know what these surgeons are doing. I don't know if they're drilling holes in my head and, they're going to make me, instead of an Eagles fan, a Pittsburgh Steelers fan. There's this sort of notion of, there's an apprehension. I don't think that the apprehension is justified after they get a chance to talk to us, but I know that out there from caregivers and just society in general, the notion is, are you kidding me? Why would you ever have surgery? Whereas I think that we can do a lot of good if we're given the opportunity to express how we can do this safely.
Another question, what's your percentage of success with DBS?
We have a really good percentage of success. I would say nothing's ever 100%, but I would say that we're probably in excess of 95 to 90. Yeah, about 95%, because we spend a lot of time on selecting patients, which means that my neuropsychiatry or my neuropsychology colleagues are excellent. My neurology colleagues are excellent. We're doing implants in the operating room with patients awake and only implanting if we believe that we have a suitable site that's been selected. So we're not just placing electrodes and hoping for the best and saying, well, good luck. So I think that there has to be rigor. And so I'm not saying that we're the only ones doing this, but that's been our practice. And that's why we can stand behind our feelings of being surgical advocates, because I think that we are thinking about the patients, not just thinking about them as surgical candidates.
And I'll squeeze in one more patient. The focused ultrasound. What do you think about it? Pros, cons?
So, I mean, it's a very interesting thing that you bring that up, Peter, because like I said in my presentation, you can tell when something's shaking. You can see that. You can't tell that your blood pressure is high or whatever. And this is 200 years ago. And so ablating that thing that's causing the shaking could be a notion. And I think that the surgical idea for treating Parkinson's up until recently with Alim Benabid and his stimulation was ablation. It wasn't until L-DOPA and the experiments in Vienna with Hornikevich that we realized that there had to be supplementation or modulation. So L-DOPA is modulating the basal ganglia. I think that electricity is modulating the basal ganglia. While I think that, yes, we can use focused ultrasound, and I think there's a lot of excitement in that, it's a destructive mechanism. And I'm not dismissing it as being valuable in neurosurgery. For instance, I think it might have a role for epilepsy. It might have a role for tumors. But I don't know that I really believe that it has a role in neuromodulation. It's almost like a step back, Peter.
Sure. Can you speak of the durability of the therapeutic benefit of DBS?
Oh man, the therapeutic benefit, it's like you saw in that video, it literally is like magic. It's not magic because there's been so much bioengineering, physiology, pharmacology, neuroanatomy that goes into it. But in the right patient, like if I have a patient that's demented, can't walk, has had Parkinson's for 25 years and they're 90, I would say that that would be somebody I would never even contemplate. So again, our success is a little bit centered around the fact that we selectively pick patients that we feel will benefit. We have a multidisciplinary meeting where we have people give their input and tell, yeah, I think we should, or no, we shouldn't. We've said no to patients because we feel that we wouldn't help them.
Dr. Sarkar, thank you very much for this great talk. And I would like to invite everybody to return to our grand rounds in 2 weeks. Thank you very much and have a good holiday weekend.
Great, Peter, thank you. Thanks so much. Bye-bye.